Welcome, everyone.
Good.
Welcome. I'm Dan Murphy. I'm Executive Director of the Mossavar-Rahmani Center for Business and Government, and it's wonderful to see a packed room here at HKS, and I know we also have many people joining us online. At MRCBG, our mission is to bring together scholars and practitioners to address some of the most pressing issues at the intersection of business and government. We do this through our research, our convenings, and our dialogues. And our work is based on the premise that looking at these issues, these critical issues, through the lens of business and government really matters. So when we think about climate change, we think addressing this issue requires regulation, markets, and innovation working together. When we think about digital currency, we recognize that governments are wrestling with adaptation, regulation, and its global implications. So that's why we started a digital assets policy project several years ago. We think that semiconductors, AI, data, and competition policy are reshaping global politics. So we started a program on technology and its regulation. And today's program, today's event, really exemplifies this approach to thinking about critical issues. We're honored today as our speaker, Dr. Monica Bertagnolli. She's former director of the National Institutes of Health and now a senior research fellow in the Healthcare Policy Program. I'm going to leave her more detailed and indeed very impressive biography for my colleague Amitabh Chandra, who will introduce her. But I did want to take a moment to recognize also Professor Chandra, who will be the moderator for today's discussion. He is director of the Malcolm Weiner Center for Social Policy. He's also professor of public policy here at HKS and also a professor at HBS. So he wears many hats, and he's director of the Healthcare Policy Program, which is housed here at MRCBG, which is thinking hard about innovative ways to increase access to healthcare, value in healthcare, and much like today's events, convenes leaders from academia, government, and industry to ensure that healthcare advances improve both outcomes and quality. So before handing the mic over to Professor Chandra, I also wanted to recognize our friends and co-sponsors for today's event at the Malcolm Weiner Center for Social Policy. So let me just say thank you all for being here, and please join me in welcoming Dr. Monica Bertagnolli and today's moderator, Professor Amitabh Chandra.
Thank you.
I think I'm going to keep this very short because we have little time with Monica, and the more time we spend with her, the better and more we will all learn. Okay. Can you all hear me in the back? No. You can't hear me in the back. Okay. Can you hear me in the back now? Okay, great. All right. So here's a few things about Dr. Bertagnolli. She's here at the Kennedy School. She's our friend. She's a senior fellow. She is a surgical oncologist. As Dan said, she ran the NIH for many years. She was recently nominated to be the president of the National Academy of Medicine, which is the group that advises Congress on big consequential health policy matters. Before running the National Institutes of Health, she ran the National Cancer Institutes. Before that, she was at the Brigham and Women's Hospital and the Dana-Farber Hospital as a professor of surgery at Harvard Medical School. I think one of the things, there's many great things we're going to learn about Monica's vision for how we could build a learning healthcare system. But one of the things I learned about you was that you grew up in rural Wyoming. And so one of your passions is thinking about disparities with an equity lens. You know, the treatments, the disparities that are prevalent here in Boston are very different than the disparities in rural Wyoming, and the solutions are therefore likely to be extremely difficult. So that's a theme that we'll examine today. And then before all of that, Monica was president of the American Society for Clinical Oncology and was inducted into the NAM herself in 2021. So she's going to talk to us for about 35, 40 minutes about this idea, which is very central to the the way we think about healthcare in the United States here at the Kennedy School around building a learning healthcare system. And then we'll spend the remaining time engaging in a conversation with Monica, where I'm hoping you all will ask questions of Monica. Thank you again, Monica, for this. So welcome.
Wow. Well, so thank you, Professor Chandra. And it is really an honor to be here today. I'm very grateful for the opportunity to have joined the Kennedy School as a fellow, and now to be able to share some perspectives in this seminar about a concept that I have been involved in for most of my career. Here's what I'm going to address with the lecture portion of today's seminar. What is a learning health system and why do we need one? I'll address our challenging history of trying to implement personalized medicine, provide some thoughts on how we can better harness the data, today's data and analytics and their power, and finally describe how learning health system approaches are essential for using AI tools for clinical decision making. So I'm a surgeon, and I've spent my career not only taking care of patients with cancer, but also conducting research in both the laboratory and clinic. I started my surgery training at Brigham and Women's Hospital in 1985, when Dr. Franny Moore was still a member of the department. The attitude then and for the preceding 100 years was that scientists stay in their labs and clinicians stay in the clinic. And Dr. Moore was the first person I personally knew who championed what we now know today as a learning health system, meaning his favorite bridge tender quote defines what this meant to him. A surgical investigator is a bridge tender, traces his origin from both sides of the bridge. He is thus a bastard and called this by everyone. At that time, and true until relatively recently, there was a very wide gap between fundamental science and clinical research. And a gap, it's this gap that a learning health system seeks to bridge. In the early part of my career, there was tremendous excitement of the possibility of sequencing an entire human genome. We started talking about a new approach called precision medicine when the Genome Project was nearing its completion. Strange to think about this now, but there were some biomedical researchers, perhaps even many, who thought at the time that the lab would provide us with all that we needed to understand disease and how to take care of people. This first reference to precision medicine in the literature that I could find was in a 1997 article, 4 years before the genome was first delivered. And this article optimistically predicted that the complete human genome, together with genomic research in other species, would lead to a complete understanding of life at the molecular level. There have been tremendous strides in understanding human biology since then, however, not only better understanding the code and how it provides just the basic building blocks, but also recognizing that the genome really is just the beginning, just the basic underpinnings of what we need to understand health and disease with enough specificity to deliver precision health. Our health is governed not only by the genes we inherit, but by the environment that we find ourselves in, with that environment producing powerful influences even before our birth. Multiple sclerosis has about 200 inherited susceptibility loci, but we now know that its primary trigger is environmental, infection with the Epstein-Barr virus, a driver of not only MS, but certain lymphomas, nasopharyngeal carcinoma, especially in Southeast Asia. And more recently, EBV has been strongly associated with risk for some gastric, hepatobiliary, and even lung cancers. Uncovering these important relationships took a combination of very large and long-term epidemiology studies, molecular immunology, and advanced antibody profiling. Both B-cell lymphomas and MS can now be treated effectively by new cell-based therapies that block harmful production of antibodies by reducing the number of CD20 positive or CD19 positive pathogenic B cells. Prevention of both multiple sclerosis and EBV-associated cancers is counting on the arrival of a safe and effective vaccine that we just don't have yet. Here's another example of how it's important to understand components of the environment, both at an individual and a population level. Early onset colorectal cancer, defined as disease before the age of 40 or 50, is clearly on the rise. The etiology of this change is very likely environmental. Why do we know this? It has a geographic specificity that is quite striking. A large multinational team led by researchers at USD recently published a report where they examined colorectal cancer genomes from 11 countries on 4 continents to investigate whether variations in the process of acquiring somatic mutations in the gut before you even saw cancer could contribute to the geographic and age-related differences in colorectal cancer incidence. They found mutational signatures produced by a genotoxin known as colobaxin that are 3.3 times more common in individuals diagnosed with cancer before age 40. These signatures were imprinted very early in colorectal tumorigenesis, and one of the signatures, called ID18, is responsible for about 25% of the APC gene, the major driver of all colorectal cancer. APC driver indels in colobaxin-positive cases. So where do we get colobaxin? It's produced by certain bacteria that reside in the gut of about 20% of people in the US today. And the incidence of colonization with these bugs varies considerably across different countries. High in the US and Europe, low in South Asia, perfectly matching the demographics of early onset cancer. Following this very strong association, the next questions to address are immediately, how are children exposed to colobaxin-producing bacteria, and what can be done to prevent or mitigate that exposure? Are there diets or lifestyles more conducive to colobaxin production by these bacteria? And how can people find out if they already have these initiating mutations in their colons? Leaving aside for now recent advances in genetic manipulation directly to combat disease, these are very exciting, but still at a nascent level. We really can't do much about the genes we inherit other than use them as a predictor of disease risk. So with the goal of keeping people healthy, we focus on environmental factors that influence health, which include not only features of the physical environment, but societal factors that are very difficult to pin down. Some things we know for sure are bad for us: tobacco use, too much sun, drinking too many martinis, excessive caloric intake. For other things, our suspicion is high. For example, does PFAS exposure cause cancer? We're getting worried enough about this to raise awareness and try to eliminate these forever chemicals from our environment. And there are many other associations with disease that are evident from human epidemiology, but the mechanisms are still unknown. We know about many of these because they're seen in the setting of health disparities. The US map of age-adjusted death rates due to cancer has looked like this for a long time, and it's getting steadily worse for some areas. For people who live in Summit County, Colorado, a high mountain community that is the location of the Breckenridge and Keystone ski resorts, the age-adjusted death rate for cancer is the lowest in the nation at 64 per 100,000 population. By the way, the average life expectancy in Summit County is a whopping 91.7 years. I think we all want to move to Summit County, Colorado, and not just for the skiing. The worst place to have cancer in the US, according to the last census, is Union County, Florida, a rural community that contains several correctional institutions where the age-adjusted cancer death rate there is 270 per 100,000, 4 times higher than Summit County. And the average life expectancy there is 67.4 years, 23 years lower than Summit County, Colorado. And that's not even the lowest in the nation. What causes these disparities? It's not just access to healthcare. It's a very complex mixture of environmental and societal factors that vary considerably across different locations. At the top of this slide, you'll see from left to right, overall cancer incidence, overall death rate from all causes, and deaths younger than age 75, a surrogate we often use for life expectancy. More data to show you that health is geographically distributed in the US is below. You see that areas with poor outcomes, in the red above, are associated with complex and difficult to quantify factors. Air pollution, poverty, more people smoking. And there's an inverse association with factors that we think are good for your health, like healthy food, higher educational attainment, access to affordable care. Research tells us that very little, if any, of the geographic association between cancer incidence and death, for instance, is due to inherited genetic tendencies. Instead, we have to consider effects from the physical environment. Many regionally distributed threats, air pollution, pesticides, other lifestyle factors, can directly affect DNA, protein levels, signaling pathways, and metabolism. Some directly, others indirectly through relationships not well understood. Emerging data on epigenetic inheritance also show that the environment can influence our health even beginning with conception. So one of the big challenges is that we lack the ability today to adequately measure and track these factors so that we can identify ways to eliminate disparities and actually improve health for everyone. Hope I'm convincing you that precision medicine, or personalized medicine as it is sometimes called, can't be achieved without understanding influence on health that exists at individual, local, national, and even global levels. I grew up in rural Wyoming, as you've heard. I spent most of my life in Boston, though. What works to achieve better health in Sweetwater County, Wyoming is not necessarily the same as Suffolk County, Massachusetts. I have personal experience as a patient in both places, and I can tell you that both locations have a lot to learn from each other. Our research goals are to understand disease and deliver effective care for everyone. And to do this, everyone has to fundamentally have the ability to participate in research. This means that we must conduct research that is not patient-centered, but also community-focused, and we need to link clinical research to routine care delivery. In 2006, the Institute of Medicine, now known as the National Academy of Medicine, convened a workshop to help transform the way evidence on clinical effectiveness is generated and used to improve health and healthcare. What emerged from the workshop were recommendations to develop a learning health system, where the best evidence to guide care is both generated and applied. It calls for bringing data to both patients and clinicians so that they can make decisions together, and also asserts that evidence generation should be a natural outgrowth of routine patient care. A few years later, the IOM issued another report specifically addressing the challenges of precision medicine. This report called out the two sides of the bridge. On the lab side, the community of biomedical researchers in the drug development industry whose job it was to elucidate disease mechanisms and discover new therapeutics. And on the clinic side, public health officials, epidemiologists, medical practitioners, and the healthcare industry who work to track disease and to deliver care. The report states that achieving the full potential of the molecular revolution in medicine requires rethinking both biomedical research and healthcare on a Flexnerian scale. The report then called for creating a knowledge network of disease that consolidates and integrates basic, clinical, social, and behavioral information and enables the delivery of improved and more individualized healthcare. All that sounded so great 15 years ago, but there were huge hurdles to overcome. Looking back, neither side of the bridge realized how difficult it would be to create a learning healthcare system when the US has nearly 6,100 hospitals, thousands of provider organizations, and 400 distinct health systems, large and small, that are independently delivering healthcare. It also became clear that precision medicine meant dividing diseases, once considered as a whole, into many subsets. So for example, today, non-small cell lung cancer is divided into 5 stages, 3 overall genetic subtypes containing 13 specific genetically defined categories that evolve over time and in response to targeted treatments. A evolving and dynamic disease, never static. And all of this matters to what kind of treatment a patient should receive at any given time. Precision medicine is certainly very complicated. Some big steps forward came from the federal government over the last 2 decades. Setting the stage was the HITECH Act of 2009, which required healthcare providers participating in Medicare and Medicaid to adopt electronic health record technology. In 2010, the Affordable Care Act called out the need to innovate, to personalize care, and improve post-approval safety monitoring of medical products. It created a supportive framework for integrating diverse data from the clinical care environment. And in 2016, the 21st Century Cures Act further strengthened this mandate by focusing on health data interoperability, patient access rights, and preventing information blocking among EHR systems. The promise of precision medicine was even called out in the 2016 State of the Union speech, where President Obama called for Congress to fund research, such as the NIH All of Us initiative, to advance precision medicine by integrating basic science and therapy development with data from the clinical care environment. But where are we in US healthcare today after all this promise? In some ways, there's been tremendous progress. During my career alone, the death rate due to cancer in the United States has fallen by 34%. Millions of cancer survivors, myself included, are here today because of advances in cancer detection, treatment, and prevention. We're seeing a new treatment and prevention advances at a remarkable pace. Cancer vaccines, gene editing, AI-driven protein classification and drug discovery, all with a promise of dramatically improving disease treatment, survival, and even cures. On the other hand, we're seeing a loss of trust in science and medicine. We're worried about the state of our public health system and experiencing a time of serious disruption in the biomedical research enterprise. Almost 20 years after the concept was first championed by the National Academy, we certainly don't have a nationwide learning healthcare system. People don't feel that we are delivering them personalized medicine on a nationwide scale. And we're not delivering the kind of care that many people experiencing health disparities need. What level of evidence, what kind of evidence do we use to make life-altering decisions for patients in clinic every day? There's a lot of information out there. I just did a PubMed search for clinical oncology, and in 2024, there were over 76,000 publications in clinical oncology. There were about 3,800 that were reported some phase of clinical trials results. This figure here on the right reminds us of the different levels of evidence that are presented in this literature. The most reliable results from prospective randomized trials that have consistent results, but a great deal of data also available from observational studies, from what might be described as, quote, real-world evidence, including retrospective cohorts, uncontrolled cohort studies, or case series. A varying degree of inability to control for bias makes these results less reliable for application to clinical care. And not going into great detail here, but a lot of methodological challenges also make these much less reliable. And sometimes it's difficult to know what you're actually reading in the literature. Oops, sorry. The National Comprehensive Cancer Network issues guidelines for cancer diagnosis and treatment. Consensus panels consistently review current results and update guidelines routinely, and a level of evidence is assigned to each guideline. NCCN, for quite a long time, has also tracked the quality of data used for each of those guidelines. Because when they give a guideline, they want a practitioner and a patient to be able to see, well, how sure are we that this is the right thing to do for you? And this is the last assessment reported in 2019. It shows for oncology, which is the medical field that has arguably had the highest level of research investment across the whole medical spectrum and the greatest number of clinical trials. The evidence used to guide clinical care is still not that great, and it actually hasn't improved over the last decade. Only 7% of NCCN recommendations are based on level 1 evidence. My own field of surgery, I'm sad to say, is probably the worst. One recent estimate is that between 40 and 50% of surgical patients are treated based on level 3 or below data. That means taking someone to the operating room, making these decisions based on cohort studies, case series, and expert opinion. That, to me, is very sobering. And this is 2025. And then it's always important to remember who's left out of all this evidence. We're missing a lot of people. Those who are older, live in rural locations, have multiple comorbid conditions, lack insurance, belong to minority groups, have rare diseases. Basically, many people here who are most likely to have a health disparity are also the ones where we don't have the data we need to understand what to do to help. This is my favorite definition of a learning health system. Evidence clinicians and their patients need won't come from randomized clinical trials alone. Clearly, we need better approaches. If we're serious about delivering personalized medicine, we need to imagine what it would take to actually implement this at a population scale. Learning health system, integrated system, which harnesses the power of data and analytics to learn from every patient and feed the knowledge of what works best back to all stakeholders to create cycles of continuous improvement. Access to high quality computable data from both sides of the bridge, the lab and the clinic, is the foundation of a learning health system. Without this foundation, we cannot expect that even the very best tools and analytics will produce the results that we need to see for our patients. So what do we want to see? Here are an aspirational vision for what we need a learning health system to do. Every clinician and patient will have the best data and evidence available to guide real-time health decisions. Healthcare delivery systems will achieve optimal outcomes for people while maximizing their efficiency and minimizing cost. Individual people, very important to this process. They will know how their health data are being used. They will have trust in our medical system, because they know where they fit into the process of what science is delivering. They can give permission for use of their health data, receive better information relevant to them specifically, and can also be notified of new research advances or opportunities from which they or others may benefit. A crucial not yet existing aspect for people with rare diseases. Innovators will produce new therapies, diagnostics, and decision support tools that enable more effective disease prevention and treatment. And finally, policymakers will be guided by evidence to effectively deliver coordinated laws, regulations, and government actions that improve public health and foster U.S. progress in biomedical research and care delivery. It is not possible to address any topic today without bringing in artificial intelligence. AI has the potential to radically transform our ability to understand and act upon the many complex and interrelated influences on health and disease. Successful personalized medicine identifies the right treatment or preventive therapy for an individual person because their condition has been properly characterized by accurate biomarkers that predict disease natural history and response to treatment. Precision medicine also requires a healthcare system that can maximize that can effectively evaluate, deliver care, and monitor patients on a time schedule that maximizes their health. At a nationwide scale, delivering successful personalized medicine is a monumental task. This is a very dense diagram of a very recent review publication just this last summer, depicting how AI is currently being used to improve diagnosis and management of patients with colorectal cancer. AI permeates the entire clinical management of this disease. Schedules x-rays and tests, improves analysis of standard radiographic and pathology images, develops new and better imaging techniques, improves disease detection rates in screening colonoscopies and by blood-based assays, and it predicts disease behavior from genomics, transcriptomics, proteomics, and the microbiome, the colibactin we need to keep track of. But to be truly useful to clinicians and patients, all of this needs to be linked to clinical data in ways that deliver the right level of evidence needed to guide clinical care. And it's a big problem when your tools get ahead of your data. There's no question that AI is a powerful new force in biomedical research and is already taking on some roles in healthcare delivery that make life a lot better for clinicians and patients. However, there's a lot more we need to do so that AI can enable safe and effective personalized medicine. Generative AI in particular carries risks today that include bias, output limitations, algorithmic brittleness, data privacy and security risks, and hallucinations. This recent National Academy's publication from the Learning Health Systems series describes opportunities and responsibilities for using AI to improve health. It proposes a risk-based framework that is actually very familiar to those of us who work in therapeutic development. Like powerful new drugs, new AI methods carry risks that must be minimized by careful product development to achieve patients' needs, comprehensive pre-implementation testing, and ongoing monitoring in all ways that they are used to maintain performance as medical practice evolves. This path you see here really was adopted almost entirely from our drug development, therapy development paradigm, where we are always balancing risks, benefits, and evolving over time. AI can deliver tremendous benefits to biomedical research and healthcare, but it absolutely will not achieve this if we don't give it the right data. The problem is that the required data is just not available today. It's clearer than ever that the most significant remediable obstacle to progress is the lack of access to high-quality, computable, individual-level data from the clinical care environment. Data that meets the needs of AI applications has the characteristics listed here. Bias and lack of generalizability are mitigated when data includes representation from the full spectrum of patients that it is designed to serve. We have a lot of learning to do before we know what this means on a societal level. Think about the disparities maps that I showed you earlier. This scope of data can only be delivered by a federated system, providing access to data across multiple, many, maybe all health systems, millions of people distributed across the different regions and serving different populations. Data must also be interoperable. Otherwise, we can't really make sense of the results. But if it undergoes transformations to achieve interoperability, it must remain traceable to its source, even on an individual patient level, so that the results can be reliably validated. Finally, health data must exist in a secure environment that is capable of implementing rules-based access at the individual patient level. And this means something different if we're going to have a federated data access. To address all of these issues, the National Academy will soon be releasing a report calling for a change in the way we view health data. The aim is to shift our attitude away from health data, from one where aggregated data is carefully secured within within the electronic walls of health systems. It's a commodity owned by health systems or other service providers. Away from that attitude to one where health data is a public utility, meaning a resource that is used for the good of all. This report emphasizes the critical role of patients in directing how their healthcare data are used to benefit everyone, and the importance of trust in establishing a system like this. The concept drives expectations for how health data should be managed to equitably drive improvements in health, including transparency, accountability, security, and adaptability to changing needs. So, with my final example, I will show you in practical terms how we need a multi-institutional learning health system approach to acquire the data needed to safely and effectively develop AI tools that can do what we need in medicine, which is to provide interpretable, reproducible results critical for personalized medicine. This could be a developmental path for a new biomarker or even a new personalized medicine decision support tool to be used in clinical care. It involves 3 parties in collaboration. First, a team of AI developers, someone developing the tool, the team developing the tool. It involves an intermediary, data broker, who ensures data security and adherence to data access rules across the many, many health system partners that are required to share data at a scale that will allow the AI tool to be developed effectively. So here's how it works with these 3 partners. First, the AI development tool decides, works with the team, works with specialists in a particular disease to identify exactly what data they need as inputs for this new tool. They send this request to a broker who then obtains the required data from a collection of large health systems who can provide data across a diverse patient population. The broker then formats and the training data from source, checks for agreements with chart review, validates that, yes, this data is really indicating what it should at an individual patient level, and then gives this formatted data that's now ready for use to train a data algorithm back to the developer team. So the developer team trains their algorithm, and then, critical next step, which is a little shocking how often this doesn't happen, sends a request for test data. It's not yet ready for application. So then the broker gets source data from a completely different, broad, diverse, independent set of health systems. Data is again formatted properly, it has edit checks, and returns it to the team. They do a test analysis, refine the algorithm. Maybe cycles of this have to happen over and over again to make sure that this algorithm is producing what it needs to accurately in Wyoming versus Boston. So perhaps only one cycle, but we probably anticipate many cycles of this might happen until an algorithm has been reliably tested and passed all of the requirements for us to be very confident that it can be used in clinical care. But we're not done, because the other thing that the learning health system needs to deliver is the ability to continually feed and train this algorithm as time goes on. So through the broker system and many participating health systems, the broker will continue to obtain and format data, and the AI development team will continue to upgrade and train the algorithm on an ongoing basis. This basically is a learning health system in action. So the future of medicine demands that we manage tremendous complexity, encompassing all the many influences on health, distilling them into biomarkers that define diseases and predict optimal treatments, and then delivering health that optimizes outcomes for individuals and society. Our implementation of learning health system principles has far too long been inhibited by a divide between the laboratory and the clinic, and between data silos created across our healthcare delivery systems. We're now on the cusp of a dramatic expansion of learning health system capabilities because of the need to develop new tools driven by AI that demand this approach. While some AI solutions may not meet expectations immediately, overall adoption of AI in healthcare is growing due to clear benefits in outcomes, efficacy, and cost reduction. So I'll end with this quote from Peter Senge of MIT Sloan School, who in 1990 was credited, I suppose, with first championing the concept of a learning organization. A learning organization is one that is continually expanding its capacity to create its future. The future of healthcare, I believe, is envisioned as a learning health system driven by collaboration between now advanced AI technologies and maybe even yet newer tools, healthcare professionals, and patients to deliver highly personalized, data-driven, and patient-centered care. So I want to thank the many colleagues who've been on this long journey with me to bridge the gap between the lab and the clinic, and of course, to acknowledge the millions of patients who've also shared that road. So thank you very much. Okay, we're good.
Monica, this was amazing. Thank you. There's so many questions we have for you. I'd like to open it up. I want to ask you one question to get us started, and the rest of you should think about your questions. It does seem like if you and I were to knock, on the door of a large hospital that has this kind of data, they would say, this is amazing. We'd love to be part of it. But my guess is they would ultimately just hang on to their data. So they would say, we'll take all these other hospitals' data, we'll put it in our data reservoir, but our data is not leaving our data reservoir, right? So we run into this in healthcare a lot. How do we approach that? Because that's like a policy problem, right? That's not a clinical problem. What are your ideas for overcoming that hurdle?
So a federated system means that nobody's data ever leaves their reservoir. Okay, so what a federated system, and that's why this approach is very unique. Okay, the old way of doing things, everybody puts their data into a big data lake, and then there's this big data lake, and researchers come to the data lake and see, well, is the stuff I need to answer my research question in that data lake? And if it isn't, they're out of luck. Very different. The way this system works is the following. Researcher comes to the broker. The broker works with all these different health systems who allow that broker to see all their data. Okay? The researcher comes and they don't say, what do you have? What data do you have? We say, what's your question? And then a protocol is developed that says exactly what data that researcher needs to answer their question. Then the broker puts out a request to all their data system partners saying, here's the data that this researcher wants. Can we visualize that within your system? So it never leaves their system. One of the interesting things about this is there's no de-identification of data. One of the things that happens is the broker never looks at the identifiers. They're not even captured. So, which is also very helpful when you think about this is a different and advanced data security type approach. So what can happen is the health system can say, I don't really want to participate in that question. But by and large, the health systems are very willing to do this. Why? The health systems are in control. They don't give access. They don't give their data away. Their data is just accesses. They don't really, their only obligation is, do we want to participate in this or not? And then the much better, big advance is that the research team is getting customized data exactly to address their question. And then finally, the more you do this, the more you learn not only what data you need, but how to actually get the data you need. So when we first started running these kinds of things, we didn't know, we're learning more and more, aided by a lot of really nice AI tools, being better and better about getting the right data out of those very complicated electronic health records.
Perfect.
There you go.
Thank you. Questions? Yes. Go ahead. Yep.
Thank you. Hi, first of all, thank you so much for giving this lecture. I found this incredibly fascinating. I'm actually from Laramie, Wyoming.
Oh, yay!
Yeah. Go Pokes. I'm wondering what you think the policy implementation looks like here at maybe a state and federal level in order to achieve a kind of federalized system of data that way, especially because so many rural communities are often the most skeptical of their health systems and, the hospitals and giving up their data in that way.
So there's two ways we could adopt these new principles, okay? The one I prefer is that this just makes so much sense and it empowers people and their health systems that, they want to participate. And I'm really delighted to tell you that that is what we're seeing. Like we don't have to force people to force health systems or even patients to want to do this because the other part of it is gaining the trust to do that is a central core of this approach. And it's another reason I like that approach, because forcing people to do something by policy, especially in this time when we don't have great trust in government and in policies, it's much better if they're the driving force behind it. So that is the preferred approach. But there's other ways that these techniques can be implemented at scale in the United States. For example, every healthcare system in the US has mandatory reporting to federal data pools, CMS reporting, CDC reporting, et cetera. So those methods could also be adapted to this procedure. And in that case, this is kind of the rules that you saw in the Affordable Care Act and High Tech Act and Affordable Care and 21st Century Cures, is that, calling for, High Tech called for mandatory use of electronic health records if you're going to participate in Medicare, Medicaid. There could be a federal government saying, well, not only that, now if you're going to participate in Medicare and Medicaid, we'd also like to see you adopt this federated method of sending data to CMS for its use to improve health. So that's a policy that could be implemented. I would hope that we could do it in both ways, and that it would be led by the trusted, accepted by everyone way first.
Hi, thank you so much for being with us today. My question is about the explosion of wearable technology and at-home diagnostics is increasing the speed in which people are generating their own health data at home. How do you see that being integrated to the framework and maybe some insights for future collaboration with the private sector? How will that look like? Thank you.
Oh, absolutely. So there is, just take that little map I gave you, the developer tool, right? It's because, okay, why do we care about wearable technologies? Well, yeah, it's nice to be able to track your heart rate and all those things, but we care about it because it improves your health, right? And all of this, not just here to, it's awful. I always have to ground us. Like, why do we do these things? Okay, grounding us is, and I'm also grounding us by saying, I want evidence that this works. I want to know if I'm spending my time with that tracker, it's really helping me. So it's the evidence that needs to be included into the evidence generation loop. So if you just look at that loop I played and you had the AI developer team, now just swap out the AI developer team and put in the tracker, health tracker developer team and see the same kind of process. Ability to monitor people, ability to see how it influences their health, and even more important, to not have that what could be critical information about somebody's health exist outside the access of their own primary care doctor and clinician. So you've raised a really important issue that I didn't emphasize a lot here, is that everything we do in a learning health system, we believe also, number one, it has to empower, make patients be part of it, but it also has to strengthen as much as we possibly can the clinician-patient relationship, because rather than detract from it.
Hi, my name is Zihua, and I'm a MPH student at the TH Chen School of Public Health. And going back to your architectural diagram regarding the data broker, so can you please explain why the data broker should be responsible for like data cleaning, reformatting on behalf of like AI development team? Like, assuming there are like tens of thousands requests from AI development teams, right? That it should be overwhelmed for data broker to do like this kind of detailed work instead of doing administration work.
Yeah. So the data broker, you're exactly right, and the way I presented it. So, first of all, the data broker does none of that work without incredibly close collaboration with the developer team, with the team that is actually going to be using the data. That is done in a very collaborative fashion. The reason I kind of implied that the formatting is done at the broker level is that the provenance of the data and all of the transformations that the data undergoes when it is formatted need to be held by the broker, because it is through the broker that any one data element or one patient record can be tracked back to its source. So I presented it that way. You're exactly right, that the broker's not the data science engine of all of this, but that formatting resides there because of the need to have that honest broker in the middle, the one who can track it back to the source, not those who eventually have access to the data. Last of all, it is not at all inconceivable that we're not doing it now, but soon we will see that there's actually just source data itself transferred directly to the data team without an intermediary step of formatting, as long as the links can still be held by the broker. Good question.
Go ahead.
Thanks for the lecture. Some part of my clinical work has been mostly in lower income context, and with some of the disruptions to the US biomedical research enterprise, any disruption that affects the life cycle from bench to patients will obviously not just shorten the timeline that patients get drugs in the US, but also in even lower income markets that have even a longer timeline. So in your view, what will the future look like with all of these disruptions?
I'm not sure I got the whole question. You mean the disruptions that we have now in our funding and our ability to engage? Yeah, I mean, it's a big problem, right? Because I believe we are a member of the global community. And when I say health for all, I mean the global community, not just us here in the United States. And when I said we can learn a lot, Boston can learn a lot from Wyoming, I can tell you that we can also learn a lot from every place in the world where people live. So I think it's very important that we continue to support the research that will allow us to learn. And I also think that learning health system approaches that really look at what is happening in a specific environment and work to improve that using the conditions in the specific environment that's been the model that has been used for global health for as long as I know. We've been doing this work. We don't expect to immediately export what we do here. So in some ways, much of what we've learned about how to adapt and learn from conditions on the ground have come from having to make decisions in a resource-constrained environment. So it just needs to be part, not only do we need to be citizens of the world, it also needs to be part of our learning philosophy to continue to improve those locations.
I think we had a question in the front.
Thank you so much for coming in and talking with us. I was thinking about some of the AI tools that might end up having clinical applications that might result or benefit from this research. I'm wondering if there are thoughts around, if these are private organizations or private companies who are the ones who own these tools, how do we ensure that the communities who have contributed their data, who especially those historically don't benefit from these tools or are kind of priced out, actually kind of see the trickle-down benefits from their data being used?
Yeah, a question for all of medicine. Not just AI. I mean, that's a question for all of medicine, and it's one that is happening that we're having to a fair degree on a societal level, even as we think, as we sit and think about disparities in the United States and the various models we might come up with that will help us deliver better care to all citizens instead of just some. I don't have an answer for you. I wish I did. I will tell you, though, that I think an absolutely essential first step is to actually include those populations in the research. That, to me, is one of the most shocking disparities we have, is that we just don't even have data on so many people. Do we have? I have another slide I didn't put as part of this set that shows where clinical trials are conducted across the United States. Well, take a look at that disparities map. It's the same thing. There are no clinical trials there either. So number one disparity is just even contributing to the data. So you're talking about we don't even have people contributing today. So I think that's at the start, even the start. The beginning of trying to understand how we can do better.
Monica, this is just really, it's expansive, it's inspiring, it's also humbling because, when I read the newspaper, you sort of think, well, or you could be left with the sense that if this cell therapy just got approved, we've made this progress. But the reality is there's so much foundational work that we still need to do. So thank you for this, articulating the entire vision. Thank you for spending time with us this afternoon.
Thank you. Thank you so much, everybody.